Okay, Assalamualaikum warahmatullahi wabarakatuh. Salam Jumaat. I think it has been 6 days from the day I posted the last video. Today I'm going to share with all of you one quite interesting topic in surgery. When you have patient with intra-abdominal injuries. So among all the intra-abdominal injuries, I just want to discuss in this 10 to 15 minutes about splenic injuries. Okay, splenic injuries. After you make a diagnosis of splenic injuries, okay, you have to decide whether you want to treat it by surgery or you want to treat it conservatively. Alright. So when you decide the patient can be treated conservatively, okay, in general speaking, any intra-abdominal injuries, if the patient is stable hemodynamically, stable hemodynamically means patient is alert, conscious, paying normal heart rate with normal blood pressure, not tachypnics, and then presented with abdominal injury, you need to perform imaging studies. You need to perform imaging studies. Okay, they will actually mention to you imaging. The most easiest and available thing is, and usually done at emergency department level, is fast scan, and they will tell you about the amounts of fluid present. That is enough. When there is free fluids presence in intra-abdominal injuries, you need to perform the next step, which is CT scans. Whether from ultrasound they can tell you liver or spleen, but you need to do another one further steps, which is CT scan, to know the grade of injuries to the visceral. In this case, spleen can have grade 1, 2, 3, 4, 5, and also you need to rule out other associated injuries. Spleens on the left side, usually associated with trauma to the lower ribs, okay, because of the location of the spleen 9, 10, 11 of the ribs, fracture of the lower ribs. Patient have fracture of the lower rib, you have to have high index of suspicions of injury to the spleen. Then patient can also have pneumothorax. Any other things that can be excluded from the CT scan, like injury to the tail of pancreas. Alright, and then on top there you can have diaphragm, okay, and you can have stomach where the greater curvature, there is gastrosplenic ligament. You can also have injury to the stomach, and parts of the colons, left colic, the transverse colon to the descending colon, that hepatic fracture, that fracture. So you must rule out other associated injuries. Okay, the principle is simple. If patient is stable, hemodynamically stable, and only spleen is injured, okay, and then the grade of injuries grade 1, grade 2, or grade 3, you can treat this patient conservatively, alright, without having to operate the patients. But you have to monitor this patient in the appropriate place. If the ICU is available, you can monitor the patient there. If not, at least in high dependency unit or acute bed, where you need to monitor it closely, look for the evidence of continuous bleeding, such as In tachycardic, patient fail abdomen getting the standards and evidence of peritonitis. Okay. To certain extent, grade 4 and grade 5 also you can treat it conservatively, but with very close monitoring, and then you have to prepare patient like patient is going to undergo operations when you need to prepare with cross mesh and all those things. So like I said, hemodynamically stable, no evidence of peritonitis, imaging showing grade 1, 2 and 3 to certain extent, 4 and 5, and then you have to have proper place to monitor these patients, because at any time this patient can go to OT, right? This patient can deteriorate. Okay, another thing, if you have splenic injuries associated with other traumas, that also contribute to the bleeding. For example, splenic injury with polytrauma, fracture of femur, bilaterals, or splenic injury with liver injuries, for example, post bleeding, or splenic injuries with severe hemothorax, splenic injuries with bleedings from other places. So in this case, there is tendency that the surgeons might choose to operate and tackle the spleens. Why? Because you are in the dilemma to monitor the bleeding. For example, your spleen with polytraumas, the bleeding can come from both, but remember, outside the abdomen you can monitor the bleeding, but inside the abdomen you don't know how much the patient bled, and sometimes you miss the boat, patient already in shock. So spleen with other polytraumas, you need to operate and then remove the spleen. Okay, you need to operate and remove the spleen, then you can have a good night's sleep. Spleen alone, you can monitor it conservatively. Example lagi, spleen and liver, because liver is the organ that you cannot remove entirely, because we depends on liver, but spleen you can remove. So you are not sure whether the spleen or the liver, okay, the spleen or the liver that cause the bleeding, which one is more dangerous. So when you open up, we tackle, inspect everything. If the spleen is shattered, we remove the spleen, and the parts of liver which is injured, we can just pack it and then monitor the patient and re-explore after 24 to 48 hours. So this is like emergency decision that have to be done to make sure patient survive. Okay, these are the case where you monitor patients conservatively. So indication for splenectomy or surgical decision when you have splenic injury is very easy. If you have patient hemodynamically not stable, started from emergency department or at casualty, the patient already showing signs of hypotension, instability, despite of initial resuscitation, BP still low, and then you bought fast scan, there is free fluid, and then see. And if patient not stable and there is no evidence of liver injury, patient is hypotension, you have to push patient to OT strips. The patient is not stable to go for CT scan or ultrasound. Just enough fast scan, patient hemodynamically not stable, BP low, patient very pale, fast scan free fluid, you have to bring the patient to OT. If you manage to stabilize the patient, you can get imaging, but the patient is hemodynamically not stable, persistently tachycardic, you need to bring patient to OT as well. If patients associated, the abdomen associated with evidence of peritonitis, because spleen can have bowel injury, you can rule out bowel injuries. So if there is evidence of peritonitis, also there is indication for laparotomy. indication of surgery. So it basically hemodynamically unstable usually need to undergo surgery, but bear in mind, at least if you can get imaging before surgery, that will be helpful. As for example, if the injury is to the liver, eh? If the injury is to the liver, you can opt for conservative or surgical management if patient is uh, quite stable, because liver is something that occasionally they can be stopped by the abdomen tamponade unless there is active bleeding, active bleeding from the vessels, active bleeding from the vessels. But if you just have liver injury without spleen and all those things, patient stable, it is best treated conservatively. So that's why when you have to rule out liver injuries, you have to rule out liver injuries. Okay, we stop at that point. We stop at that point where decision to perform surgery. Okay, let's say patient had underwent surgery where splenectomy been done, mean removal of spleen, and then post-op. So how we monitor this patient postoperatively? Okay, this is specific for spleen, postoperatively, and some of the patients postoperatively stable, they can be monitored in the ward, basically at acute bed. With the one that is unstable, usually associated with other traumas, other injuries, they will be monitored maybe closely in ICU. So post-op splenectomy, what are the things we have to monitor? Okay, all post-operative procedure, there is standard monitoring, observation, vital signs, and looks for evidence of continuous bleeding. This is standard. Means like patient pass respiratory rate, patient tachypnea or not, patient tachycardia or not, good urine output or not. But for specific for spleen, you need to know what are the complications that can occur, post-operative. That's why you divide the complications into immediate, delay, and late complications. So immediate, what we do during splenectomy? We remove the spleen. So remember, there are organs nearby the spleen. The first one is diaphragm. Okay, not rare, but not something that cannot happen. You can have trauma to the diaphragm. So we have to monitor the respiratory rate, look for signs of tachypnea. Okay, if patient have fracture, look at the chest tube. Okay, so they can have diaphragmatic injury or diaphragmatic paralysis. What else? You can have stomach here. Stomach attached to the upper pole of the spleen where the short gastric artery. So we have to clamp this part. When we clamp the gastrosplenic ligament with short gastric artery, occasionally it is very close to the stomach. Okay, so that's why we put rice tube intraoperatively. So we have to look for signs of gastroparesis. That's why there is rice tube. So we keep the rice tube for 24 hours post-op just to relax the stomach, empty the stomach, to prevent patient from having gastroparesis. So we look for that. If the patient keep on vomiting, keep the rice tube first. So what else? Here at the hilum of the spleen, there is tail of pancreas. So in splenectomy, we ligate the splenic artery, splenic vein, and then the attachment to the colon, splenic fracture. So the tail of pancreas here, if you don't ligate properly or you miss the distal end, we don't ligate it properly, sometimes you can catch the tail of pancreas. So they can have fistula later, pancreatitis. Okay, apart from that, base, floor, splenic bed, and they can have oozing here and there, so they can have bleeding. So that immediate complications, usually bleeding from the arteries where the ligature can sometimes snap, so they can have bleeding. So this thing you can monitor by looking at the heart rate, patient pale or not, Immediate complication, bleeding. Respiratory problem, diaphragmatic injuries. Gastroparesis, patient will have ileum because of close to the stomach. These are the immediate things. So you monitor lah patient heart rate, you monitor patient respiratory rate, and you look at the patient rice tube, look all those things. So these are the things that you have to look for. And then 2 or 3 days after the operation, what happened when spleen being removed? We have to monitor for evidence of thrombocytosis. Okay, thrombocytosis happen because spleen already removed. Spleen is an organ where it platelet destruction occur at spleen. Platelet. So when spleen is not there, so platelet can increase because of lack in the platelet destructions, mature platelet increase. So you monitor normal platelet 150 to 400,000. So you look at this platelet count every day, and sometimes they can increase, slightly increase 5, 6, 700, no problem. But suddenly increase to 1,000, 1,200, you have to be very careful because this can trigger thrombosis, embolisms. So we need to tackle these problems. If it consistently increase, there is a role of plasma paresis. But started with hydrate the patient, or replacing the patient blood with plasma, or give anticoagulant to reduce this. So you have to look for that. Okay, then you can have fever. These are the things that can happen. Fever post-op usually can happen. The other causes that common like atelectasis can cause fever also post-op day 1, day 2, day 3. And this, if the blood you didn't put drain and there is collation post-op and there is hematoma at the splenic bed, they can become secondary infections and other causes of fever. So these are the things. And then late complications. Okay, like I said just now, pancreatic, they can have pancreatic fistula, but this can come with persistent abdominal pain and all those things with breast and anomalies. Okay, the delay complication is late complication is the condition what we call is OPSI, overwhelming post-splenectomy infection. So OPSI happen because this patient without spleen, they are vulnerable against gram-negative capsulated cocci, such as meningococcal, pneumococcal, and influenza and all those things. So they are vulnerable to this infection, and if they get this kind of infections, the consequence is catastrophic and mortality is high. So that's why patient before discharge, we have to give patients triple vaccines against this capsulated gram-negative cocci. Alright, so that patient will not develop OPSI later. So if patient, for example, age less than 21, you need to continue the penicillin V 250 mg BD until the age of 21. And after that, if patient have any short surgical procedures, they will need to be given prophylactic antibiotic against this organism to prevent OPSI. And that OPSI, if patient age 21 and above, you don't have to give. But there is current guideline where they want to give until the age of 23, but it's actually debatable. And last but not least, OPSI. OPSI incidence is about 1%, and higher in elective cases of splenectomy. Because in elective cases of splenectomy, you remove the spleen, for example, for aplastic anemia, or any elective procedures like you remove the spleen electively, mean you remove the whole thing. So there is no spleen in the body, so definitely there is no IgM left from the spleen. In emergency, where you do operation emergency, there will definitely shattered spleen. There will be spicule of spleen maybe left in the peritoneum at the end of surgery. So this remaining of spleen, we call splenoculi, can actually provide spleen, IgM in the body. So you rarely seen patients with splenectomy following emergency splenectomy develop OPSI. So the risk of patient develop OPSI in emergency splenectomy is less than compared to elective splenectomy. So that is reason. But if patient develops OPSI, walaupun incident dia 1%, mortality is 50%. So if let's say you have two patients sit next to the next and both develop OPSI, one person will die. So that is a brief, I think brief discussion sharing about management of OPSI, especially you doctors now doing round for this kind of case. So when you look at the patient post-op spleen, bear in mind the earlier you need to monitor the heart rate, evidence of bleeding, look at the right stomach, look at the respiratory rate, and look at the platelet. Then before discharge, you give patient triple vaccines against gram-negative capsulated cocci, and then you need to advise patient to get prophylactic antibiotic whenever they are going minor procedures such as dental procedure or surgery later on. And if patient age less than 21, continue the penicillin until age of 21. If after that, don't have to give the antibiotics. So that is briefly about how you monitor patient with splenic injury. Thank you. Assalamualaikum.